with a spinal abscess. I have nothing to disclose. So basically, some of you guys will be considering, like, wondering why we were talking about this talk, despite the making sense title of this talk. It's because we need to get back to the basics. A lot of patients in epidural abscesses are missed or misdiagnosed or mismanaged. A lot of times we'll miss those patients, especially when we refer them to the infectious diseases. They don't get back to us, and some of them will have a failure of non-operative options. I wanted to highlight that a lot of papers are talking about the high risks of failures, but they're not necessarily an indication for surgery, and the importance of early diagnosis and intervention. And one of the issues with the surgeons is the OR availability. So as many of you guys, surgeons, are having issues with the OR time, and since these patients are having infection most of the time, we do them at the end of the day, not with the best team, but you need to have the ownership of the patient. You need to keep up with the investigations and asking other services to be on board. Also, the importance of having a biopsy, as many of you are having issues with having interventional radiology to obtain biopsies. This is a major issue in some hospitals to get the biopsy so they can act accordingly. The location anatomically in the cervical spine or thoracic is more important than the lumbar in terms of compression, given the size of the canal in the lumbar, which is more than the others. But also the patient's factor are playing more important role than the location. So this is a study was done about the cervical spine epidural abscesses, a systematic review. The treatment options were medical antibiotics and versus surgical intervention. They wanted to analyze only the cervical spinal epidural abscess to determine the optimal method between these two methods or two options. It's basically an electronic literature review of case series and retrospective reviews for patients conducted for about 5 years until June 2016. And then the data and the study quality assessed based on 2 independent reviewers. They found 927, of which 11 were included. 4 paper studies were having a good quality, and 7 ranked fair quality, a total patients of 173 with a mean age of 55-year-old, with male being more predominant. The IV antibiotic was the most common risk factor, not the IV antibiotic, sorry. The IV drug abusers are the most common risk factors for developing cervical spine epidural abscess. The Staph aureus is the most common, and we know all of that from our studies. In these patients, 140 underwent initial surgery, and then 18 patients were surgically treated upon failure of medical treatment, and then 15 patients were treated only with antibiotic. So the conclusion of this paper was saying a significant portion of those patients treated with antibiotics are experiencing a significant failure, between 30 to 40% in the thoracolumbar spine epidural abscesses. This is another systematic review by the AO spine. It's probably the only one I found talking about the thoracic per se. And they were like, in their paper, they were talking about this paper. If you can see here, a significant portion of those patients, if they present with paresthesia or paraplegia in the thoracic spine, there is a chance of having 50% of non-recovery. So in their groups, 9 patients were treated with thoracic spinal epidural abscess, 7% of them having a paraplegia upon presentation, and 6 of them did not recover following the laminectomy or the surgical intervention. So it's like more than 50% did not recover, indicating the importance of the thoracic compared to the other ones, the cervical or lumbar. In this paper as well, they were talking about having significant high rate of failure of antibiotic if it was only treated, not adding to it surgical intervention. They mentioned all of these risk factors, and they make sense: the BMI, the diabetes, ESRD, and patients above 70-year-old, and if the deficit has been more than 5 days. This is another paper as a review talking about the same risk factors, and they were talking about predictive factors for failure. So they're not indications for surgery, but I would say they're more suggestive of surgery. So diabetes, high ESR and CRP, leukocytosis, and bacteremia. And if there's any significant weakness, age more than 65, MRSA, and having neurodeficit, which makes sense. But if you have more motor deficit than sensory, that makes sense even more to intervene. If you have a pathological compression or vertebral fracture, if the patient is having active malignancy, which I'm going to show you in one of the cases. And then if you have a progression of a bony deformity, which I may not agree with, but it's one of the risk factors they mentioned. So this is a patient of mine. He's very healthy. He's young, in his 20s. He presented to us with a paraspinal pain. He was actually seen by a neurologist who referred him to me after doing an MRI. And we were questioning about sexually transmitted disease based on the history of the patient. And when I saw this one, I was saying, this is an HIV patient. There is no question about it. And actually, when we investigated him more, he was having an L5 and osteomyelitis and spreading to the epidural abscess as well as between the paraspinal muscles. This is a very interesting case. She's a 40-year-old female known to have a low back pain and radiculopathy. She was diagnosed about 4 years ago with squamous cell carcinoma of the uterine cervical uterus. And then she received chemotherapy and radiation therapy with a significant dose. And then a few months after that, like about 6 months, she started having a bleeding per rectum. Sigmoidoscopy was obtained and then showing an ulcerated rectosigmoid mucosa. So this is basically a radiation-induced proctitis, which was treated conservatively. She came to the ER a few months after. She was neurologically intact. Hemoglobin was normal. White blood cell was very high. CRP was very high as well. She could not get the MRI given the pain she has. X-rays is not significant other than having a spondy at the L5, which sometimes overlooked or underestimated. But this patient was having this active cancer, has been treated. So the picture is not taken lightly. We have to shift her to the ICU because of her level of consciousness was altered with hypotension, a remarkable CT scan, and then she grew mixed gram-positive and gram-negative. She was on antibiotic, broad spectrum, and then it was staph angiosis. A few days after, the patient have unequal pupils and reported CT brain, shows interval development. She was having right thalamic hypodensity, representing an impulsive infarction. She was having an anterior temporal periventricular cerebritis. An EVD was inserted by the neurosurgery with a CSF analysis. She improved clinically because of the antibiotics and antifungal. So we could not get an MRI for her, but if you can see here in the epidural space, the black line here, it was basically a rectal ulceration of the rectal wall, and then there was a creeping between the rectum and the epidural abscess, which we could not explain, and then traveling all the way to her brain. She was neurologically intact, though, and then in this argument, would you intervene? Would you make her better? She's actually clinically improving. But we had a lot of back and forth with the general surgeons and the obstetrician whether to do like an epidural abscess evacuation, but we need to control the source, and that's the major thing. So we called the general surgery. They did like one of the techniques to close that ulcer or the defect in the mucosa of the rectum. And by doing that, we controlled the abscess spread. She's been doing fine. A few months after a few days after she had acute kidney injury, which resolved, and she's doing fine now, I was like one of the patients I thought she's not gonna make it. So the take-home message is if you have somebody with an epidural abscess at any level, with any deficit, basically, you need to jump on it and get it done as soon as possible. Antibiotic is not only not gonna help in that case, but surgery is taking superiority based on the literature. But you have to keep in mind, if you don't have anybody with any neurological deficit, then non-surgical option is an option. but there must be a significant failure to the antibiotic response. And following up with the patient is the key to get them back and see how did they do. Thank you very much.